I'm Dr. Olivia Scheller, Medical Director at the Institute of Medical Education and Research. Welcome to IMER reporting live from American Society of Hematology 2011 meeting. I'm here with Dr. Andre Gua, Director of the John Thierer Cancer Center from the Hackensack University Medical Center. Thank you so much for joining us today.
My pleasure.
We're going to go over non-Hodgkin's lymphoma, and I thought we'd cover three areas of non-Hodgkin's lymphoma today with the questioning. First, diffuse large B cell. We'll also cover follicular lymphoma, and we'll also cover mantle cell lymphoma. So let's start with diffuse large B cell. So, what are the ongoing strategies right now? I know we have R-CHOP 21 that have been reported here at ASH to improve on this regimen.
So at this point, R-CHOP 21 remains the standard of care in large cell lymphoma. There's been effort over the years to try to improve the outcome of patients with large cell lymphomas with more dose-intense therapy, R-CHOP 14, or upfront consolidation with high-dose therapy and transplant, which have not panned out to be superior to R-CHOP 21 so far. The other strategies have been to try to stratify patients and understand better prognostic factors in patients with large cell lymphoma. So beyond what's called the International Prognostic Index, we have actually now molecular subcategories with the germinal cell subtype or activated B cell subtype, which have been defined about a decade ago now, and we are going beyond that now. Clearly, the ABC subtype do worse than a GC subtype, even in the R-CHOP era, but what we saw at ASH is further stratification within the JC especially, with presence of a 14-18 translocation or MYC rearrangement or MYC amplification that both can give a very poor outcome in patients with a germinal cell subtype. There were also additional markers looking at immunohistochemistry, which will make it more readily available beyond the Hans model, which is duplicating, or the Choi model, which are duplicating the activated B cell type and germinal cell subtype classification. There were a number of abstracts looking at additional model and immunohistochemistry markers that would help us moving forward to try to stratify in these patients better. So there was a model with 6 genes that was looked at in the context of CHOP and R-CHOP setting from the ECOG large cell lymphoma trial, which will need further validation in a prospective setting, but are interesting direction to try to stratify better this patient with large cell lymphoma. The use of functional imaging also has been looked at in patients with large cell lymphoma to try to early on decide if a patient is chemo-resistant and potentially should be switched to high-dose chemotherapy. There was data presenting at ASH this time looking at the impact of deciding early on a PET scan after 2 cycles of R-CHOP that actually are not very promising, that even switching to high-dose therapy and transplant doesn't seem to be beneficial. So there's still an unmet need in that situation. We are developing additional strategies by combining R-CHOP with novel agent, and these trials are underway and hopefully will improve the outcome of our patients. The Germans have looked also at something interesting, looking at more intense regimen with rituximab based on pharmacokinetic studies that are for now in a phase 2 setting and appear more promising, but will have also to be validated. So overall, there's a variety of directions that are being looked at to improve beyond the R-CHOP 21 that remains the standard care, and there's a large ongoing trial also from the CLGB that is looking at R-CHOP versus R-EPOC, which is an infusional regimen, also looking at gene expression profile, that the trial is on the way and will be completed soon. So hopefully with all these strategies, we'll be able early on to modify our treatment and our approach in patients with large cell lymphoma and continue to improve their outcome.
Let's talk about the relapse setting. As you know, when a patient relapses, worse outcome. Can you talk a little bit about what came out at ASH here and what holds promise in the relapse setting?
The large cell lymphoma who relapse after R-CHOP chemotherapy represent a challenge. The typical management is to use salvage chemotherapy followed by stem cell high-dose therapy and stem cell transplant rescue, called autologous stem cell transplant. The patients who fail R-CHOP within less than a year and who have a secondary IPI of 2 or more actually have very poor outcome even with high-dose therapy and transplant. So there's a number of strategies that are being developed to try to look at better options in those patients. From combining with a new small molecule in a relapse setting, this is early, but also potentially new antibodies. And there's actually this morning presentation with a combination of ICE with ofatumumab, which is next generation anti-CD20 that binds to a different epitope at the surface of CD20 that appears very promising, especially in the patient with these poor prognostic features that I just mentioned. Additional strategies that are being looked at in a relapse setting is also to consolidate patient post-transplant, and there was a number of abstracts that are looking at this, including using lenalidomide post-transplant or rituximab, although the combination seemed to be very toxic. There are also a number of new agents that potentially will be very interesting in that setting to integrate in our management in the future.
So let's move on to follicular lymphoma. Here at ASH, there was data on what best induction chemoimmunotherapy to use. Can you talk a little bit about that and the data that came out here at ASH?
Sure. The management of follicular lymphoma is actually more controversial. Historically, there was no clear benefit of treating patients early, so there was the watch and wait for a long time until patient required therapy, and there was no impact on survival of treating them early. There was interesting presentation at ASH from a variety of perspectives looking at a very large group of patients that have been put in a longitudinal observational study called the Lymphoma study, and that had close to 3,000 patients with follicular lymphoma, and looking at the pattern of care both in academic centers and in the community setting. So from these presentations, what we learned is that the best results seem to be the best mileage, if you want to say, especially in the poor risk patient, the high FLAPs, is when using R-CHOP comparing to RCBP and fludarabine. This is similar conclusion to what the PRIMA trial had shown, which also had this 3 regimen as a frontline therapy, where the R-CHOP also did better. There's additional options that are being looked at in patients with follicular lymphoma, is also bendamustine that from the famous STEEL trial, which was BR versus R-CHOP, where the progression-free survival was significantly better comparing to R-CHOP. So there's a variety of regimens that are being used. But what is also interesting from the Lymphoma study, what we learned is the issue of watch and wait, which is somewhat in flux and still very controversial. So there was a very important presentation last year at ASH actually looking at watch and wait versus rituximab early on versus rituximab followed by maintenance. And this was a very provocative observation, and obviously there was a delay to the need for using chemotherapy in a patient who received rituximab. So from the Lymphoma study, they looked at the patient who received rituximab versus watch and wait and the impact on the time to the next therapy, but also the response to the next therapy. And this was very provocative because in the patient who actually watch and wait, the progression-free survival with the R-chemo at the time of needing chemotherapy seemed to be worse than the patient who had received rituximab. So I think this is really provocative and will continue feed the debate of the watch and wait data. There's another aspect that was also important presented at this ASH for follicular lymphoma using rituximab again is that can we use rituximab and do a maintenance or wait until the patient relapses after induction with rituximab and treat that relapse. And this is the RESOLVE trial that was presented at ASH as part of the late-breaking abstract, showing actually there was no difference. So you can actually wait until the patient relapses, and obviously the patient who get more rituximab get further delay in terms of the need for chemotherapy, but to a much higher price. There was no difference in the quality of life in that trial or in toxicity, but there was no clear benefit of a scheduled maintenance versus waiting.
Well, you just mentioned rituximab maintenance therapy, and I think this is one of the biggest debates here in follicular lymphoma. Can you talk a little bit about the debate and what kind of the data that came out here at ASH that either supports it or doesn't support the use of rituximab in follicular lymphoma maintenance?
Well, maintenance rituximab has been used because patients typically continue to relapse after induction with R chemotherapy. So clearly the data, and there was a very large randomized trial, the PRIMA trial that is now published, that has looked at a variety of R chemo regimen with a randomization maintenance or no. And this was a maintenance every 3 months for 2 years, and every 2 months for 2 years. And the patient who had maintenance actually did much better in terms of progression-free survival. This has also been shown now in a relapse setting, and I think this is clearly improving the progression-free survival. The debate is that are we going to really improve the overall survival? Are we going to potentially make patients more resistant if they had more exposure to rituximab? And these are going to be really a benefit at the end. So this is still a matter of a debate, but clearly, although the conclusion increased progression-free survival. There's also an issue with maintenance with toxicity, and certainly depending on the schedule of maintenance as well, but toxicity with hypogammaglobulinemia and the respiratory infection that also feeds the debate of the need for the use of the maintenance or not. Additional strategies were looked at in this and during this ASH meeting to try to consolidate also after our chemotherapy and instead of maintenance to look actually at radioimmunotherapy. And there was a number of abstracts looking at the impact of radioimmunotherapy and maybe new ways to look at radioimmunotherapy from single lesion in the frontline setting with everolimus, taxane, or Zavalin to consolidation after a short course of our chemotherapy. All of these data are very promising, especially potentially in very elderly to whom you don't want to give too much chemotherapy. And finally, there's also very exciting data from combination of biological and rituximab in follicular lymphoma. And this is data that was presented actually last year at ASH with a little bit of an update this year, looking at lenalidomide and rituximab in a combination with follicular lymphoma, where the results are quite impressive and leading to a phase 3 trial that will compare lenalidomide and rituximab versus our chemotherapy. And finally, in follicular lymphoma, what's also interesting is the development of new monoclonal antibody. Can we go beyond rituximab? So the GA101, which is a second generation glycoengineered antibody, that appears to have a type 2 antibody, a much better ADCC, so binding better the effector cells, and with very interesting, promising results. It's early, but in a phase 2, in a randomized setting against rituximab, appear to have a slightly higher response rate and higher CR rate. This is also being looked at in combination with our chemo to replace the rituximab, so G-chemo with CHOP and FC, fludarabine and cyclophosphamide, but also other antibodies such as ofatumumab that is also being looked at again in combination with chemotherapy. And there was an interesting abstract presented with bendamustine ofatumumab in a frontline setting in follicular lymphoma with also very promising result in a phase 2 setting. So there's a variety of compounds from antibodies to radioimmunotherapy to additional small molecule as well. And at ASH we had the CAL101 story, which is a PI3K inhibitor that targets the B-cell receptor pathway and with activity in a variety of lymphoma and CLL, but also in follicular lymphoma. And we had for the first time the presentation of trying to combine the PI3K inhibitor with chemotherapy or monoclonal antibody in a relapse setting with very promising results as well. So the landscape of follicular lymphoma is evolving with a variety of options that will potentially develop in a patient who have options for non-chemotherapy options in a frontline setting, but also new strategies for consolidation or maintenance.
So wonderful new strategies in follicular lymphoma. So I'd like to move over and talk about mantle cell lymphoma, which I know is a topic that's very interesting for you. Can you talk a little bit about the new perspectives in mantle cell lymphoma here at ASH and all the new data?
Mantle cell lymphoma is somewhat of a challenging lymphoma where the overall survival has clearly improved, more than doubled over the last 2 decades, but still a challenge, especially in the relapse setting. And also because of diagnosis, mantle cell lymphoma, the median age of diagnosis is in the mid to late 60s, making it difficult to use the high-dose therapy up front. So there are interesting strategies that are being looked at to develop non-dose intensive regimen in the patients who are not high-dose therapy fit. And there was data presented from the German looking at R-CHOP versus FCR, followed by a maintenance with rituximab, where the result was very much in favor of R-CHOP, with maintenance rituximab, sort of defining the new standard of care in a patient who are not eligible for high-dose therapy or dose-intensive therapy in a frontline setting. In the relapse setting, mantle cell lymphoma is also a very active field of research, given the fact that this disease is very chemo-resistant. And so there's a variety of compounds, especially the proton tyrosine kinase inhibitor, or BTKI PCI 32765, that was presented at this ASH, focused on mantle cell lymphoma in the phase 2 trial with more than 60 patients. Half of them were bortezomib naive, the other half had already received bortezomib, all were relapsed refractory mantle cell lymphoma, heavily pretreated. The response rate was up to 70%, with no difference in a bortezomib exposed or bortezomib naive, and also no difference regarding the number of prior therapy or poor risk features in mantle cell lymphoma. So this is very promising, and obviously with a very easy toxicity profile as well, with very little toxicity, a little bit of GI toxicity and fatigue, but no myelotoxicity. So it's going to be great to potentially combine with other agents in mantle cell lymphoma. In a relapse setting, and actually also in the frontline setting, there was interesting data presenting combining HDAC inhibitors with chemotherapy. So this was a combination of SAHA, cladribine, and rituximab in a frontline setting with an abstract that showed that the response rate was phenomenal, 100% and 80% CR rate in a frontline setting in mantle cell lymphoma. So this is also an easier option for these patients who are not high-dose therapy eligible. There's a variety of other molecules, also the CAL101 or PI3K inhibitor that has also activity in mantle cell lymphoma, mTOR inhibitors, and additional targets, second-generation proteasome inhibitors that will also be looked at in the setting of mantle cell lymphoma. And that makes it very exciting. What was really as overall landscape at ASH this year, what we saw is that the confirmation first of the large number of novel therapies that are in the pipeline, but starting to see them integrated into the management of our patients with a conventional regimen, or sometimes replace the conventional regimen with combination of biologicals. And I think that was very interesting. And finally, there's a little bit of a immunotherapy about ASH that was very interesting with bispecific antibodies, and also another field that is developing, looking at blinatumomab, which combines an antibody structure that combines CD19 and CD3 and breaks the tolerance, if you want to say, to the tumor cells. And the activity has been shown previously in follicular lymphoma and mantle cell lymphoma, but there was also activity reported ASH in diffuse large cell lymphoma, refractory or relapse post-transplant, where clearly there's an unmet need. So the landscape, again, in non-Hodgkin lymphoma is evolving dramatically with a variety of agents and a better understanding of the biology, and hopefully we will be able to develop in the near future more molecularly relevant clinical trial test-based trial or biomarkers-driven trial, and which will allow us to decide on the treatment of our patient and improve their outcome.
So this is very exciting times in non-Hodgkin's lymphoma. It seems like the landscape is rich, and I thank you very much for reviewing all the data, exciting data in non-Hodgkin's lymphoma here at ASH. Thank you very much.